Welcome back to another podcast of Heal Without Harm. My name is Dr. Clayton Dir, physical therapist and the one bringing you the truth about the medical system. Today I've got special guests. As you notice, I said guests because there's two of them. I want you to meet Dr. Teralyn and Jenn Schmitz, the co-hosts of the nationally acclaimed podcast, The Gaslit Truth. With a unique blend of expertise and lived experience, they challenge conventional views on mental health and medication. Jenn, a licensed therapist with a master's in clinical psychology, is a holistic de-prescribing consultant who helps individuals safely navigate the process of tapering off psychiatric medication, integrating brain health, mindfulness, and wellness practices. Dr. Teralyn, a PhD in psychology and expert in brain health, advocates for a paradigm shift in mental health care. She combines her background in psychology and holistic nutrition to promote safe medication practices and brain health over symptom management. Together, they offer critical insights and empower listeners to rethink mental health care through their podcast, The Gaslit Truth. Teralyn, Jenn, welcome to Heal Without Harm.
I always get weirded out when people do a bio about me. I'm like,
I know.
oh, man.
Like, did I write that correctly? Like, I don't know. I feel like there's too much information. It's just like.
I think I was genius since I was the one who wrote it. You know what I mean?
Oh, did you write it? You wrote that? It is genius. Maybe it's just me. I have trouble listening to my own accolades from somebody else. That's it. That's the whole problem.
Damn accolades. All those lettered therapies we got over the years. Oh, boy.
Too much.
I'm probably going to have to talk about all that bullshit, huh? Oh, can I swear on this?
Oh, 100%. Yeah. I just got to make sure to click the right button.
Man, we're 2 minutes in and I already swore. All right. I keep it together so you don't have to edit that.
But I know what you mean. The thing I resonate most with right now on social media is that post where it's like, I don't feel accomplishments. I feel like an obligation to get them done type of thing. So it's like hard to celebrate it. So when you are either reading what you've done or hearing the readings of what you've done, you're like, yeah, that was just part of the process, right?
Yes.
Yeah.
Too many certificates and all the things. And now it does feel like obligatory education at this point.
It really does. Mm-hmm. Yeah, it really does. Especially when you do coaching, like, you have a coaching practice and as de-prescribers, right? Like, yes, it's helpful to have a degree, right? Because we've got expertise in psychology, but the licenses, all the extra things, right? Like, don't really need all of that to do some of the cool stuff we do now. And it's like, gotta save myself.
By the way, after 20 some years of practice, at least for me, I feel like I've done every continuing education program that's out there for therapists, and it's just lather, rinse, repeat over and over and over again. It's so boring. Anyway,
honestly, I'm not looking forward to that because at times I'm like, what do I even want to learn? I feel like I know some stuff, and it's like you said, you're 20 years and I'm 5. Like,
yeah.
I'm supposed to get 40 hours every 2 years for the next 15 plus. That's bonkers. So I really want to get into this because I know that we're already going to run over on time because
we
there's so much to unpack. But there's also so much to unpack. So I want to dive right in, and I just want to start with this myth that built the pharmaceutical empire, and that's the truth on whether or not the chemical imbalance theory is even close to accurate. Can you guys give the listeners just a quick background on what is the chemical imbalance theory? And then your take on true, not true, or what parts are true.
Sure.
Go from there.
I think we could probably make the whole episode about this. Probably. Or maybe not, because I'm at this point where I'm just like, okay, it's not true. It's never been true. It's never been proven as true. It was a marketing, basically, pitch by Big Pharma that stuck around for way, 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 way too long. And
it's still here.
It's still here.
Actually still here.
Still here.
Just conversing. Terry and I were just conversing yesterday, the day before, about a client who was just told you have a serotonin imbalance. Yep. And here we are, how many years after this was debunked, and yet it is still being told today.
Yes. So, we're going to say a couple of words. We're going to say disproven, debunked, all the things, or just never proven.
I was going to say, was it ever bunked? Like, was it ever proven in the first place?
No, it's
actually
never
wasn't.
been proven. Mm-hmm.
What's the idea? What's the lie that's being sold?
That your mental health issue, whether it's depression, anxiety, or basically anything else, is driven by basically a singular neurotransmitter. So if we can just go to basics, it started with Prozac, I believe. Correct, Jenn? You can always correct me if I'm wrong. I believe it started with Prozac, and the Prozac theory is that if you're feeling depressed, that you are serotonin deficient, that your body does not produce enough serotonin. Okay. That's the entire premise of the thing. And so basically it's the theory of broken brain. You were born this way, you were born broken, and over time it's just gotten worse. And now you're in this spot that we have this solution that is going to give you, and this is also a lie, more serotonin. Because SSRIs don't make you create more serotonin. They disrupt how your neurons communicate, essentially. So holding on to more serotonin is the theory. The thing is that even when we're talking about medications, medication is still a theory. They're not exactly sure what medications do or why they, quote unquote, I'm air quoting now for anybody, work. That word work, they're not even sure. They're still running more theories about why some of these medications might, quote unquote, help somebody, right? So there's still a lot of operational theories that have never been proven in medication and in the chemical imbalance theory. And I'm ready to just put that theory to bed, tuck it in nicely, and walk away from the room because I'm sick of it. I'm sick of that being the reason why. The reason why now people are dependent on medication is because they've been sold this theory, this lie of a theory that was really a marketing gimmick. And now they are forever consumers dependent on medication, which, by the way, they now have chemical imbalance because of the medication, not because of the problem. Right. Yes. It created the problem that it was supposed to solve, which then we can talk about withdrawal if you want to. And I think Jenn has some great lived experience in that, but yeah. That's where I sit. I'm pretty passionate about this because I'm irritated by it. It's such an irritating thing to have to share over and over and get such pushback over and over and over, even with our clients sometimes.
What is some of that pushback though? Because like I've got, the theories that I have to go up against, like, which to me is probably much less significant of like, no, I promise you can let your knees pass your toes when you squat, right? Like that's going to hurt people much less than like them being wrong on that myth is going to hurt them much less than taking a lifetime medication and being wrong on that theory. And so to me, it's like, okay, why would anyone want to go against that? Like, by the way, it's not just something that's deficient in your body. You don't need this medication. You can actually, help yourself in all these other ways. And I know with the posts that I've put on social media or podcasts that I put out there, people are like, no, it's this way. And it's like, why would you want to fight this necessarily? And so like, what are some of the things when you guys talk about, hey, by the way, it's not a chemical imbalance. What weird negative comments have you received by and large?
People have this belief that, the psychiatric medications are sold to individuals as the fix, as the thing that will work. So when you think about the start or the etiology of why someone would take a psychiatric medication, they're already in a compromised, vulnerable space of some sorts. It's not like you're coming into your provider and you're saying, I feel really great. Things are okay. It's not bad. You're already low. So you're coming in a space of desperation, of needing help, of not being able to think probably super critically or clearly anyways, because when we are depressed or when we have anxiety, that does impact higher order thinking. Our prefrontal cortex is being impacted by these things. Not how it does once we introduce a medication into the mix, but we're in a compromised space and there's desperation. So we come in and we're sold a bill of goods of this can work. Let's try this. There's low risk.
It's safe. It's effective. It's all the words.
It's been used for years, many, 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 many years. This drug has been around since the 60s and it's been being used. So people start there and they're given this story. And
wait, I want to add one more. I want to add one more layer to that story before you move on. And it's not addictive. Because I do think that people go in and ask, like,
man, do I piss people off with my addiction posts?
Mm-hmm.
Oh, that's a whole nother, man, we could go on and on about this. That's right. I kind of forgot about that. I've had some quiet on social media with this. This is some of the feedback that when you're asking about what do we get pushback on, that's a big one. Your brain at that point is not addicted to any kind of a substance. Okay. So you're coming in and it's a clean slate, but you're needing help. So what you're sold is, here's the help. It will help you. It's not going to harm you. There aren't these long-term effects. The things that are usually asked are to you are, tell me a little bit about your depression. Know that this does sometimes create suicidal thoughts in some people. That's something they will ask. That's at least the one part of informed consent that I was given over the last 25 years.
They do that in such a mild
Very tiny
way.
little, yep,
right.
It's about the only one, right?
Mhm.
Like, so you start this with hope. You start these medications hoping that they're going to get you where you need to go. And so I think that's the first stage of what this looks like, is the space that you're in and wanting to just have some hope that things are going to get better. So then you start the medication, and oftentimes things for many people don't get better. There's a period that you go through where you're having some side effects, and the feedback that you receive from your provider is you got to stick it out. Like, it's going to take more. at least 6 to 8 weeks, or we need to up the dose. For some people, unfortunately, they get med stacked early on, even before that first medication has enough time, and I'm air quoting this, to be effective. So you put yourself in another compromised position, because as this medication is going into your body, it is impacting your brain's ability to think critically. You start to believe the story that something's wrong with you. You truly do, because look, I'm taking these meds. I need more over time. I got to switch to something different, and it's not getting better. So you start to believe this story that was handed to you, and that there's something wrong with your brain, and we need to even this out, and that this medication will do that. So that becomes part of who you are, and it becomes part of your story. And the side effects that happen, you don't blame it on the medications over time. You start to say, it's a me problem. I'm having issues with my libido. It's a me problem. I'm not sleeping well. It's a me problem. I have anxiety now, and I came in for depression, but now I'm anxious. That must be a me problem. And unfortunately, the providers, the prescribers, contribute to this story, because they're not sitting here asking you about your lifestyle, and they're not fully asking you all about what's going on in your life. They never fully ask you about what the hell's going on in the first place when you go in and you say you're depressed, because typically it's something going on in people's lives. There's a story.
Well, and there's times where we kind of should be depressed, right? Like, that's part of normal human function,
100.
right?
For sure.
I mean, I know with Brooke Seam, right, that I've talked to in the past, and I know you guys know, is like, her dad passed, and it was fairly traumatic, and like how everything went down. Like, homegirl, you should be going through like significant grief for a while.
Yeah.
And I think it's like, those are these like beautiful entry points in an opportunistic healthcare system where they're like, there it is. All right. Yep. You're depressed. We got you. Right. They're like this like savior coming in on a white horse, but they don't, like, people don't realize, like, okay, and also you're never going to come off for the rest of your life.
They don't say that, though. That what they say is, it's okay if you take this forever. Some people need it forever. You might need it forever, and that's okay. That would be the stigma of mental health if you think you don't need it. Oh, by the way, if you get better, it's because of the medication. It's not because you don't need it anymore. There's so much going on around that conversation. And by the way, I wanted to point out, a lot of times when you go into the doctor's office, they'll do a screening, like a screening tool. And those screening tools were, this is the so
Dion,
messed
this
up.
is going to make me so mad.
I know.
What you're gonna say. I'm already
so messed up.
And I'm so mad I didn't know this 20 years ago when I started.
I know, man. When Jenn and I were trained to do psychological evaluations, like, I didn't know this stuff. I did not realize that these screening tools that are used in doctors' offices were developed by Big Pharma as a way to sell more medications originally. That is the origination of those checklists. What is it? The PHQ-9 or whatever is one of them, I believe. There's others. And then after that, of course, they have to, research them to prove them worthy to, to identify depression and things like that. But I'm like, these were marketing tools. Like a guy made this checklist to help sell more medications. And that checklist became the gold standard of, screening people. And now, but then we've also conflated screening with diagnosing. So a screening tool isn't meant to be a diagnostic. It's meant to be a screening tool, So then when you're supposed to go and get a formal diagnosis or whatever, but instead you'll get the screening tool, which, by the way, is so basic that most people could check off a lot of those things, like how you're feeling. And also it's, what is it? Is it like the last 2 weeks or something? It says in the last 2 weeks, are you feeling these ways? Right. Yeah. Clayton, you had something.
So I remember in PT school, I remember this little snippet. I don't remember what class it was in or anything, but they essentially had found, like, again, what we're starting to talk about is like how we were taught is the problem in a way, right? Because you guys didn't know this and now you do. And you're like, what the hell? I remember they said that they essentially boiled it down to 2 questions that screened like well over 50% of the time that someone is depressed. And it was, have you, I don't remember both of them, but one of them was like, have you lost, I think it said in the last 2 weeks, do you notice you're not as happy doing things that you previously enjoyed? And then in the last 2 weeks, have you lost your sense of hope? And like that caught all depression. So if like you say yes to those, or if your patient says yes to those, like they're depressed, like refer them on, give them some drugs. And I'm like,
think about a teenager. If you're going to the pediatrician if you're a girl and you're going during certain times of the month, like when you're more emotionally up and down, you're going to catch that person at that time. Or let's say your boyfriend broke up with you, or you lost the big game, or there's a test coming up that you're worried about, in the last 2 weeks. Yeah, but you need more context around those conversations, not just, oh man, you scored this on this. You're probably going to need some medication right now, right? And by the way, parents are so fear-based in those offices, because if you don't medicate, your child might take their own lives. Wouldn't you rather medicate them than have them off themselves? And I'm like, listen, the majority of people with depression and anxiety aren't out there trying to end their lives. That's an extreme response to everything. The majority of people are just trying to live their life. Right.
And just for reference, so the PHQ-9, which you're talking about, which is this is something that is often used in doctors' offices. In fact, like I had the PHQ-4 given to me the other day. It's literally 9 is because of the number of like scoring questions that are on here. But what it is there's a depression screening, and it's the last 2 weeks, and it asks you little interest or pleasure. And you score 0, 1, 2, 3, based on your answer, not at all, several days, I think. And then one is like every day is your last scoring column. Feeling down or depressed. These are the questions that they ask you. Do you have trouble falling asleep? Or do you sleep too much? Do you have little energy? Appetite fluctuations, right? Problems with concentration, such as reading. By the way, I would have said yes to all of these so far, everybody. Because that's called life with a lot of these. And then there's another one about like suicidal ideation or thoughts to hurt yourself. That's it, everybody. So what we're talking about is this idea that these questions are asked to you. A diagnosis is given to you, which is required by insurance. And
to get a medication.
So you're labeled with something based off of a tool or an assessment that was created,
a screening
by Pharma.
tool.
And the thing that sucks about this is I didn't know this, right? As a clinician, like I had no idea the roots that Pharma had within my field until like the last handful of years. And 16 years ago, when I started in this game, I didn't have a clue. But to go back to what you were talking about, Clayton, the way in which we were educated, truly, I mean, and you talked about this when you were on the Gaslit Truth podcast, there is a disease model that we were educated within. And it's a model of bringing people back, creating a forever consumer. And in the case of Terry and I in our field, whether it's with prescribing or even in big psychology as therapists here, because we can talk about that model as well, we can keep people coming back forever and create these forever consumers. And when you're on psychiatric medications, the thing that starts to happen that people don't realize is the medications impair your ability to think critically. So over time, you don't start to go, maybe it's the medication. You go back to the narrative that you are sick, something is wrong with you, there is an imbalance in your brain. And unfortunately, as you continue to put these medications into your body, your ability to have self-awareness, to feel emotion, to have higher order critical thinking, it actually becomes impaired. So it's an iatrogenic level of care, and what I'm talking about is Peter Brigham coined this term, being spellbound, where essentially you will never ever be able to see that the intervention that you're doing is actually causing you harm. And it keeps you there forever then, because you actually can't think critically anymore to see that these things happening to you over time are actually a side effect and caused by the medication itself, the treatment.
I think too, it's all wrapped in like almost like a metabolic dysfunction. Because I remember there was, at least that's what it appears to be, right? Like,
yes.
I remember there was like one paragraph that I like highlighted, circled, like earmarked the page and stuff in Brooke's book, where she was like, I went back to the doctor saying I had this. And he's like, okay, cool. I'll send you to an endocrinologist. And then she's like, oh, I have this. And they're like, okay, we'll send you to a dermatologist. Oh, and I have this. And then it was like, okay, now you have 4 specialists.
Yeah.
So now you have 4
care.
doctors. Yes.
Mm-hmm.
Now you have 4 doctor bills. Now you have 4 different opinions that none of them really make sense. It's just a pill from each one of them, instead of like, I wonder if there's something I'm doing in my life that's creating these problems, whether it's lifestyle change or the drug on top of poor lifestyle. Go ahead.
I want to add in, because when you go to different specialists, like, it is unlikely, anyways, this is just my personal observation and opinion. It is unlikely that specialist is going to say the psychiatric medication is probably causing this. Because other specialists, they don't ever want to mess with someone else's work, right? So they're not going to mess with someone else's prescriptions on anything. That's a problem, because then nobody's going to speak the truth to that
Nobody
person.
helps take full responsibility for that patient.
Or take responsibility.
Yeah. It's like when they come into your office, like, this is your chance to kind of audit their entire health history, or at least ask questions on it, or have them think about said questions. Because otherwise, like you said, it's like, oh, hold on. We'll leave everything as you are. Let's just add this one medication because I think this will fix some things. And then the next provider doesn't want to step on toes. They'll just add one. Yes. And it's like, hold on, can we just like audit these 9 prescriptions that you have written down on and then copied for every doctor you go to? Because I don't know if you need all these. And so like some questions that I've asked in clinic and is like, patient comes in, back pain of like 9 months, for example. And then I notice like plus or minus that 9 months, like plus or minus 1 month from when they start having back pain, they start taking this medication, regardless of what it is. I'll just be like, what is this again? Like, what's this one for? Most of the time I know what it is, or I've Googled it to double check.
They don't know,
what's it for? Or they'll say, oh, it's my blood pressure med, my water pill, right? They'll just generically name it. And I'll say, have you noticed any negative side effects since starting it? And I would say it never really goes anywhere, but hopefully it at least starts planting the seed of like, I guess that is about the time I stopped sleeping through the night. Or maybe that is when I started getting more irritable, or just something to stop provoking this. Because I know for me, it's like very out of my scope, but at least having them ask questions. And then hopefully before they leave a plan of care with me, they advocate for themselves and they just start asking.
I don't think asking questions is out of anyone's scope, to be honest. I
agree.
Yeah, you're not doing anything, but I think when we think about side effects, I think people are looking for specific things. The side effects for me too, and this is all, retrospective, were metabolic. And, and my thyroid suddenly became an issue. And then I was on, pre-diabetic medication after these, psychiatric medications. So, and that was all within the first year. So these things started happening very quickly for me, but nobody ever put it together that that could have been the precipitator. It was just, you're a tired mom and, these things happen and you're overweight. By the way, that all started because of the medications, right? So when you put on 40, 50 pounds and, would you rather be a little overweight or would you rather not be depressed? Well, I was depressed and a little overweight and I couldn't move around as easily. So that's a stupid thing to say to people. Yeah, on the meds. Yeah. And then all these other health problems came up, but those health problems aren't publicly related, right? We don't talk about them as if they are related to a psychiatric medication in any way, shape, or form as a side effect. When you're talking about these meds, I think people think that they are heat-seeking missiles and the only thing that they're going to impact is your brain. These medications impact every cell in your body, every cell, every organ, everywhere. They don't just go, to your brain and go, okay, let's work out the serotonin in your brain or whatever. No, they impact every cell in your entire being. So it makes sense to me now that, yeah, that makes sense that my thyroid would be checked. And it makes sense that, diabetes might be a thing. It makes sense all of these metabolic processes would happen, but yet nobody put it together. I was one going to specialists for each thing, the same thing, but nobody put it together for me. As a matter of fact, I just put that together within the last couple of years because we had a guest on our show that was talking about the impact of thyroid and psychiatric medications. And I was like, what? Yes. Oh my God. Why didn't I ever think of that?
Well,
right.
And that's a huge piece of it. Clayton, what you just said when you were talking about what you flagged, the area that you flagged in Brooke's book, there are so many individuals out there who, including myself, I have gone through this. I'm pre-diabetic. Shocking how all of us who are on these psychiatric medications are being told that they're diabetic when I'm like
she's the poster child for a good lifestyle, but
I am. I was gonna say, like, if you're gonna put somebody on like a poster of like eating clean and exercising in a way that's healthy and good for your adrenals and nurturing sleep like a son of a gun and working through meditation and mindfulness, like throw my name, like put me on a banner. So it makes no sense, right? But we are often told that this happens to us. There are
part of
so
life.
many
It's just
people.
part of aging. It's just part of post-pregnancy.
It's part of aging. Tell me about your first degree relatives who had diabetes. I got this whole spiel. Let's start the pre-diabetic protocols. And I'm sitting here going, is nobody connecting psychiatric medication and metabolic functioning? And so that is so common. And I guess it's kind of like one of the hills I'll die on here is the metabolic functioning piece. If you think that psychiatric medications only impact just your serotonin, you're grossly inaccurate. And I think that's really important to know. It's every cell,
your whole body needs serotonin, by the way. So
it's everything.
Yeah.
So
don't get me started with pregnancy.
That's what I've learned about neurotransmitters and hormones, both. And there's a piece in here that I'll ask you guys about hormones later on, because that's one observation I've made in general with motivation and getting things going and then happiness and all that kind of stuff. So we'll get to that. But I was curious because I don't remember where I heard this. I don't remember if it was a TikTok or like that one dude, Adam Ruins Everything, where he just dispels everything on Comedy Central a long time ago.
Yep.
Whatever it was. But there was a campaign in either the late 80s or in the 90s that they realized that if they started prescribing psychiatric meds, people probably wouldn't take them. And so they're like, okay, before we start selling these things, we need to tell everybody that taking meds for your brain is like taking meds for your blood pressure.
Oh, no, for your diabetes too.
And so they did this whole campaign to prime the whole general public.
Yes.
So that people would be more accepting to take these meds.
It's all marketing. These people are freaking genius. When they spend way more money on marketing than on research and development, that's a problem.
Well, it doesn't have to be true. It just has to be believable. And the thing is once you get away with it long enough, like you guys said, they've been doing it for years.
Yeah.
That becomes the research. No, this is horseshit. There was another guy that, it was Sean Stevenson. I don't remember the exact numbers, but it was well over 50% of all medications approved by the FDA are pulled back within 4 to 5 years because they're like, oh my God, this is causing a lot of problems. It's because the real research is give it to everybody and see what happens.
That is the real research. We're all a research project at this point. At this point, we're all a long-term. Well, we're all in the long-term research project now because I have so many people that were prescribed these things in the late 80s, early 90s, because that's when it really came out. Mommy's Little Helper, Prozac. And that's when everybody was looking towards, antidepressants to solve their worldly problems, right? But now these people are hooked on it. They're 60 years old now. And they're coming to the office and they're like, it's time for me to take my life back. And I'm like, oh my God, you've been on this for 40 years, 30, 40, you are the long-term research project right now.
Mm-hmm.
And the amount of health related problems that these people have, and not to mention they're never on just one medication for 40 years. Now they are on 3 or 4. And sometimes therapeutic duplications or more, you know, you were talking about how do people not know, you know, your care providers, they don't do these. Cause I'm like, they don't even do drug interactions half the time. You know,
the amount that I've caught and family members or like patients that are coming in for their knee pain is pitiful.
Yes.
Like, I took 2 pharmacology classes. Why am I the one catching this?
Correct.
Like, are you kidding
Correct.
me?
Okay, but this kind of goes into this idea you were asking us earlier, Clayton, about like shit that we get heat for on social media, and like what are people getting so upset about, right?
A PhD talking about psychiatry, that's what they get upset about,
right? And this is one of the things that like Terry will go on and will boldly talk about this. I recently have put a lot of stuff out on my socials about this and how I am literally an expert in informed consent.
Yeah, by definition.
Yes, I'm an expert in it. And people get so upset because you're not a prescriber. Like you haven't taken years and years of psychopharm. And I kind of laugh at that because like we did have to take a significant amount of psychopharm. And what we took was so biased and one-sided. It was disgusting. It was like all the great benefits to like, it, of course, like the serotonin theory was in there, right? All these things. But one of the things that we get a lot of heat for is that exact thing, in that we are to stay in our area of expertise. But like you, right? The reality of this is we have learned how to resource the shit out of ourselves as practitioners, but to help resource our patients and teach them, here's how you go look up drug interactions. Here's how you find what actually can be contraindicated. Yes, I know you're on a significant amount of supplements and amino acids, and someone told you that was all good for you, but you're taking blood thinners and you're taking psych meds and you're taking all of these things, right? And so we've had so many clients that we catch that are taking psych meds that contraindicate themselves, that they shouldn't be taking, or like medical meds with psych meds. And so we have become experts in truly looking at risks and benefits and alternatives for people.
Yeah.
And people don't want to hear that. They get really upset. Like, you're a therapist. You're a deprescribing coach. You're not an expert in informed consent.
But I'm going to tell you, if
like
we
I
were
would almost ask them, so then who is?
Right. Really?
That's
Is your
true.
provider? Because the white coat got you in this mess. And now you're coming to me to help get you out of this mess.
But I will tell you, if I were on there talking about the benefits only of psychiatric medication, nobody would question my PhD. Nobody would say a damn thing about, well, how dare you talk about this? You're just a PhD in psychology. Nobody would say that. But because I'm saying, listen, these are risky things to do, how dare you talk about this? You're going to kill people. And I'm like, sorry, Big Pharma's already doing that for you. Like, I'm not doing it. They are. You know, where is their culpability in all of this? It's missing. It's gone.
We've talked a lot about the problem, right? And so the thing is I don't, like, for my wife, for example, she's on an anti-anxiety medication and has been a long time and is happy with the benefits. And I'm like, babe, I don't want you on this forever. So like at some point in time, we need to figure out how to get you off of it. Because I don't, like, I've read enough, I've learned enough, yada, yada. I would say as of right now, I don't think there's any major problems. But at the same time, like pregnancy 1 went fine. Pregnancy 2 had, not geriatric, the pregnancy diabetes, what's it called? When you have diabetes during pregnancy?
Yes.
There's a word for it.
Is it preeclampsia? No,
it was just, she only had like lack of blood sugar control during pregnancy. The placenta was pulling the sugar.
I know what you're talking about.
Baby, she was good.
Like gestational diabetes?
Gestational.
There you go.
I knew it was another
I'm
G
like,
word.
I don't know where we're going with this.
Early this morning when we're talking about this stuff. Go ahead. Yes.
The coffee's almost all in my blood.
I
so
got
we're
you
good.
guys.
So anyway, so it's starting to beg more questions, right? And so I know this is where you guys like hit the home run, or maybe it's just you, Jen. I'm not exactly sure, but what does it look like if someone calls you up and they're like, hey, I've been on this med. Let's call it sertraline, which is Zoloft. Okay. I've been on it for 5 years. It's not horrible, but I also have like been reading some things and I don't want to be on it anymore. What would you tell that person, or what does a plan of care look like with you? Or like, just what do those steps look like from like phone call to, oh my gosh, I'm finally off. I'm me again. Thank you.
I feel like I get 2 kinds of people. I will get people that come to me and have already that figured out their truth. And by that, they come to me and they're like, I've been reading the books. I've been looking at the articles. I've been listening to your podcast. Like damn Robert Whitaker from Mad in America, you ruined my life because now everything I know that I've been sold is wrong, right? Like I'll have people that will come in and say that. Some of them have already like gotten themselves like a deprescribing manual, like the Maudsley's deprescribing manual, and they've started to look at that, right? Like, so I'll get clients that are in that space. There you go. That fantastic thing. Thank you, Mr. Horowitz, right? So I'll have people that come in and that's already part of their world. And Terry, you can chime in too if there's, you know, a different space. Then I have people who I start seeing who maybe just have a little bit of curiosity, and they'll maybe start to come to me not to get off their medications, but they'll come for like brain health stuff and to like start working on optimizing their brain health. And even sometimes in my therapy practice, I will have people that come just to see me for like mental health therapy. But they come because they're intrigued by like the holistic alternative piece that I like blast all over my website and my social medias and things like that, because I'm just not like the traditional therapist, right? And if they start meeting with me, they start to ask questions about like why things haven't gotten better for them. And it naturally opens the door to let's talk about all of the medications that you're taking, because these are questions that it's funny. We do these biopsychosocial histories, these big histories as clinicians that we do with our patients, but we don't do shit with what they write down. We only focus on like the mental health of the psychological piece, but we don't go significantly into the medical history. And if we do, we draw these siloed parallels that make absolutely no sense. But again, this is how we were trained. So I get these two schools of people that typically come in. For the ones that, don't have all the awareness and knowledge and are kind of just slowly kind of interested in things, I at least start by going through their story and what you were just saying, Clayton. Because if most people put together a timeline and you walk through your story and your history and you put together, here's when medications entered. We put together big life events that happened. We like environmental events all the way down to medical events. And you put together this beautiful timeline. It really helps people kind of take a look at what came first and how things in their life morphed into more medical interventions that were given to them. And oftentimes in that process, people will sit back and it's like the light bulb just dings. And they'll go, holy shit. So I started these meds when I was younger. I've been told for 20, 25 years that they're helping me. But then I had issues with my libido and I lost my sex drive along the way. And I had terrible acne, horrific acne that I ended up having to go on Accutane for. And then I was having metabolic problems and stomach issues my whole life. And I couldn't figure out where the pain was coming from. And then I ended up being told like I needed a sex therapist because I like had
Jen's
no
talking about
sex
herself
drive.
right now. This is
my
Jen's
whole story,
personal
everybody.
story.
Okay. And then I had issues with
Allegedly.
pregnancy and
Allegedly.
I couldn't get pregnant, right? But these are such real examples. So I'm just like, I'm going to rattle these because this is very real for so many people. And then I couldn't get pregnant. And for 2 years, I was on all these drugs to try to get pregnant. And I was told there's no hope for you. And you're going to, it is what it is, right? We've done all the things. You're in an in vitro land now. You need to look at that, right? And then you're told there's metabolic issues. You start losing hair and you can't figure out why you're losing all your hair. And so along the way, right, all these things start to spill in this timeline. And so I like to do that for people. That is usually super helpful. And then the education starts to come in. And then I start giving people resources. And then they get to a space of truth where they're like, okay, I really need to look at this differently. That's typically what I will do for the people that come in that are just like, oh, I'm just here to help my brain because I have depression. I have anxiety. I want to feel better. And it turns into their story, which oftentimes is then jaded with typically significant amounts of psych meds, polypharmacy, and even medical.
I think getting that story is important because there still is then, I hate this word, but like more buy-in to the process, right? Like this doesn't make sense. Like when we start pointing out things that don't make sense as to why you're here in this level of medication. Like for instance, I just had someone who was medicated in their late 20s because they survived a hurricane. And now this person is in their 50s and they've been polypharmaed ever since. And I said, are you still in a hurricane? Like, what's going on? You know, like, are you living in this hurricane? And they're like,
Right.
I know, I don't know what happened. Well, what happened was dependence and addiction to certain classifications of medication that they were on, inpatient stays, all this stuff. Like, then their brain really was toasted. But as far as like walking someone through the process after that, after all of that is done and you get the rapport and you get the, you know, the buy-in of their story and you understand them deeply, like I like to do a lot of labs for people. I like to use labs that they've had done in their physician's office that are looking at well, you know, complete a CBC and also micronutrient labs, and I direct them to do certain things. You know, the one lab that you got to ask for is vitamin D, which is like astounding to me. I don't understand why it has to be
There is so much research
asked.
on how like deficient people are on, but like it's never tested.
Never. And you have to ask for it. It's not in a typical panel when you go to have a physical done. You have to ask specifically. So I give them a list of specific things that I want them to do. And then we can also look at, it's a neuroadrenal panel that we do, which looks at, it's the best way we have so far in modern science to look at levels of your neurotransmitters, because now they're going to be upset, and also cortisol, which is your stress hormone. So we do these panels for them as well. And then as much as possible, collaborating with their prescriber, whoever that is, if the prescriber allows the collaboration. I want to make that clear, because I always talk to them about, we have to collaborate with your prescriber, because your prescriber is the one prescribing these things, and literally the one that is deprescribing based on, you know, the hyperbolic tapering plans, if they're willing to do it. And I just had one old school psychiatrist tell the client that they'd be willing to entertain an email with me. That's what they said. I'd be willing to entertain an email with her. And I'm like, well, okay, you know, and so well, thank you so much. The collaboration is weird to me. Like, why wouldn't you want to collaborate with?
Because there isn't one, right? There isn't. And I
mean, I could go down conspiracy theories and all the stuff about how they're not going to have a client for a while. I'm like, dude, this stuff, they've been on this for 20 years. It's going to take years. To deprescribe somebody. My rule of thumb is 1 to 3 months for every year you've been on it. Could be more, could be less. Yeah. So that's the length of time. And people go, oh, that feels hopeless to me. And I'm like, well, but I'm not going to sugarcoat what this is. And I'm not going to say you're going to be off of this in a couple weeks, because you've tried that before and it never works out.
Yeah. And that's just it. That's the carrot. To clarify, you can go faster. People do this, and it creates significant withdrawal and irreversible harm. If done too quickly. It can. Yep. Absolutely.
Well, and one thing I think a small superpower of mine is, once I see enough stuff, noticing small patterns, and then it takes me a while to be able to regurgitate that back in a digestible form for the person I'm trying to communicate with. But one thing I've observed with physical therapy and physical injuries or pain, and then I would say it seems pretty similar in the psychological world, is if someone is going on one of these medications, let's say they've been on it 5 years, and they don't like the negative side effects that they're experiencing, especially when you spell it out and all the metabolic dysfunction, they can keep going and kind of ignore it and say, it's not that bad, right? And so let's say it's 2 out of 10 discomfort, or 2 out of 10 level of essentially troubles for them. Or they could go through 6 to 12 months of absolute hell. At least that's what it seems like from Brooke's experience. But almost infinite upside afterwards. And that's what I've observed too with physical therapy, is like some people are like, I don't want to walk down that, whether it's they don't know if they're capable, it's too inconvenient, or
they don't have the support.
Don't believe you. That's another one. Yeah, they don't have the support. But it's like I promise you, what you want is on the other side of this. Unfortunately, I'm sorry to be the one to have to tell you, but it's not going to be easy. But the thing is if you tell them, it'll be just 2 weeks, you'll be fine. Like, that 2 weeks in a day is going to be a very hard day for them, because you said blah, blah, blah. Yes. And they still have a long road ahead of them. So thank you for not sugarcoating it for these people. I do want to, just because we're getting low on time as anticipated, what does just walk me through a snippet of like, what is deprescription? Like, do they take less meds? Do they like take half pills? Do they take one every 3 days? Like, are you talking to them the whole time? Like, what does this process look like?
Depends on the medication, actually.
Okay.
Okay. So I think one of the reasons why prescribers, and I call them prescribers because there's a lot of different medical professionals that can prescribe now. So not just psychiatry. So when we're talking about this, I have worse information with nurse practitioners, but anyway,
NPs,
so
general doctors, OBGYNs,
right. Anyway,
for it.
well, that's a whole nother conversation. But it depends upon the medication. But the problem is with prescribers is that they can't. I don't know that they. I shouldn't say they can't. I don't know that they can look outside the box in how they prescribe the medication the way it needs to be looked at for the deprescribing process. Meaning, aside from taking something or compounding it if possible or turning it into a liquid, there are medications that are made in certain milligrams, right? So like if, 75 or 50 or 25, right? So they will prescribe it in that way, which is appropriate, right? So 75, your next prescription down would be 50. I'm just making stuff up, right? So that's how they're going to prescribe it. Well, what they really don't know is that, once you hit this marker, you are going to be in severe withdrawal. So you might start at 150 of something and you get down to half. So they're like, oh yeah, I'm down to 75 and I feel fine. That's because you haven't hit the train yet. Like the serotonin occupancy. We're actually going to be doing a really good episode on that coming up. So if you guys want to hear more about that, particularly tune in. But anyway, it's called cert occupancy. But there's a whole chart. Once you hit the spot that your receptors are no longer full and they're starting to essentially pull off of the receptor, you're going to start feeling that withdrawal more and more, which is why the lesser amount of milligrams you get, the harder the withdrawal becomes. Which is also why if you pull someone off at 50 or do 50, 25, or the every other day bullshit thing that people do, which really just disrupts people's brain worse, you're going to be in a terrible position soon. Likely. But when you deprescribe, you got to get real. And people don't like this. You're going to feel like a freaking drug addict half the time because you're going to be measuring and crushing and weighing. And hopefully you'll have a prescriber that will give you liquid. Hopefully you're taking a medication that is not extended release that you can get it in liquid. Otherwise you have to change forms over to something that's not extended release, which can put you in withdrawal again. So it really is medication dependent, the form of the medication, how it can be prescribed. But you really do need to get artsy about this. I'll say it's pretty artistic. People take a tablet and they'll take a file and they'll file off just a smidgen of it and weigh it, and that's the next level dose down. Okay. Yes. So that seems like, and it is a lot of work. Jen's been doing this for 2 years. She's lucky she's got a liquid taper, which makes it easier. But every day she's thinking about, what's my milligram today?
How do I syringes out? And every single day,
it's a lot.
I've been doing this for two years, every single night, getting the right dose, trying to figure out how to do it. It is an art form that is very individualized.
That's the thing. That's the whole thing right there, Jenn, is that this is such an individual thing for every person. It's about reconnecting the person back to their body too, right? And not just doing as I say, right? It's about It's about this idea that you have to learn what works for you, what feels good to you, what feels bad to you. And we've outsourced all of that information to any provider, including a psychiatrist or psychologist or therapist. Everything about us has been outsourced to somebody else to fix. Okay. Yes. So I want to roll this back for 1 second. So when I say like, oh, listen, Jen's been on this, but Jenn was on something for like 20 years. So she's been doing this taper for 2 years. It's going to take longer. Like she's got more to go. Okay. People are like, oh, Then they go to their doctor and their doctor's like, I can get you off of that in 2.5 weeks.
Yeah. She's
Oh, yeah, I'll
crazy.
take that instead. Like, that sounds way better to
Yes.
me than grueling over this for 2 years or more. I'm like, but come back in 6 weeks and they're going to put you on something else because now we've established a quote unquote new baseline for you. This is who you are without medication. You haven't been on meds for 4 weeks. This is your new baseline. No, it's not. No, it's not. Your brain has not healed. It is not a healthy brain yet. That just takes time. And now you're probably going to experience protracted withdrawal and things are going to fall off the rails pretty quick, or usually within that first year somewhere. People will come back and be like, oh, I need to be on something. This is terrible. And it's all because of the way that they were deprescribed in the beginning. So this is why this isn't such an individual, slow, careful process. You have to be careful because the risk of time for people taking their own lives is when they start, stop, increase, or decrease the medications. So that's when the people are at the most risk, and we fail to see that. What we'll say is if they're in the deprescribing and they feel like they want to take their own life, well, that's the return of your depression. You need something else now. And it's like, no, that's just really your brain kind of recalibrating, your body and brain recalibrating to the circumstance of not having that drug in the system again. So
they always have an answer, right? Of like, oh no, that's not your fault.
No, it's exactly, it's not your fault. And there's so much to this. And the amount of pain that Jenn and I, even just in the Gaslit Truth podcast Gmail, when we get that, like we ask people for their stories and we get them. And I get people emailing me all the time. And sometimes I just sit back and go, this is too much for me. Like, this is too much for me to read over and over and over again, these people's stories of harm, constant harm because of psychiatric medication, who have been gaslit. They gaslit themselves. Like, I don't know how many days in a row I've gaslit myself when I was on meds that I'll just stay on, it'll be fine. Like, all this stuff, like blah, blah, blah. But then gaslit by their friends and family. Who are you going to be without this? We don't like who you are right now when you're going through withdrawal. We don't like that. You don't know what's best for yourself. We know what's best for you. All these things, the amount of pain that comes streaming in our email inbox is beyond reason. But I think for me, it's also what keeps me going, knowing that there's so much pain out there, that there's so many people to help, right? And we're not going to get to all of them, but I figure if we can use our voices, that maybe they can find other people that can help them too. Or other practitioners will decide to be like, oh, these two people have a lot to say, and it's actually pretty damn interesting. And maybe we can help change some of the language around, mental health therapy too, or therapists. That's kind of my bigger goal here. So
there's a gentleman that I followed via his podcast since about 2015. So now it's been 10 years and I still listen to him off again, on again. And I tell you this story because I want to let you know how much impact you guys are probably having without even knowing it, right? So for probably every email that comes in, there's probably 10, 50, 100 people who are being impacted but not sending you that email. Right. This gentleman had a podcast called the MFCEO Project. His name's Andy Frisella. And he actually took, I think, 2 or 3 years to come off. I think he had Lipitor. Is that another one?
Sure.
And so he said, this guy literally wrote a book called The Book on Mental Toughness. He's the one who developed 75 Hard. He said it was the hardest 2 years of his entire life, even though he's built huge companies and went through some crazy hell. But the thing is, as I was thinking about it, because now that I'm a podcaster, now that I'm putting out content, I question, am I doing anything of value, right? But then I think about like, okay, well, who would listen to this and would they reach out to me? And then I'm like, well, I listen to people. Do I reach out to them? And it's like, sometimes not. And I think about the impact that he's had, because in 2015, I was about to graduate undergrad, trying to get into PT school. Then I didn't get into PT school, had to go to PTA school. And then that was a 40-minute drive. So I started listening to podcasts then. And that's when like impact started to take place. And I was thinking, oh my gosh, this is inspiring me. I'm motivated. I'm like angry at certain things. I'm like, all right, I'm going to go do all this. And the whole time I'm like, okay, when does this start happening? Like, when do I finally get to, like get some success? And it's like 10 years later, I'm 6 months into this podcast and I'm thinking I would have never got to this point if I hadn't been listening all along. And so it's just, the thing is it just takes time. And the one thing that he always said was, you have to, his like particular statement is, personal excellence is the ultimate rebellion. And so taking care of yourself, nutritionally, sleep-wise, physical fitness, all of that kind of stuff is going to be the best rebellion, because ultimately you're not a consumer of the healthcare system anymore. That's not the point of the statement, but that's a huge one. And then you can't be susceptible to these lies, these narratives and stuff. And ultimately through that right there, like that statement is like what's continued to drive me. And it's what I want to put in every patient that I talk to, everyone that's listening. And I think you guys want to do the same ultimately, because it's going to start pulling people out of the system ultimately. And so with all that, I want to say, and then the last thing was, when you start taking care of yourself, people see that and then they'll slowly be like, I kind of want to do that. And so it's like, if you can get through that hard time of withdrawals where people like don't like you or don't like putting up with you, they'll eventually see your success, even though they were never there as a cheerleader, it seems. And then they're like, well, maybe I should do something. And then it'll inspire and move on to the next one. But man, is it grueling and a silent battle along the way.
It's very grueling. It takes a big toll, but I remember when Jenn and I got our first email from the Gaslit Truth, we're like, oh my God, we got one person that's listening. This is great. But I think, what you just said is true. For every one email we get, there's other people that still remain silent, but they're listening and they're paying attention. And I think that's important to note. So you guys better get to me before I retire. So I'm not going to be working forever.
There you go. Hey, so at least on my clock, we've got 4 or 5 minutes left. Do you guys need to jet out of here?
No.
And finish up. Okay. No. 2 or 3 rapid fire questions here to finish out. What's one thing you wish every doctor knew about SSRIs? Which, for those listening, I know we could have defined this earlier. Selective serotonin reuptake inhibitors is what SSRIs are. The general anti-anxiety, antidepressant meds. Back to you two. What's one thing you wish every doctor knew?
More than one thing.
I wish they actually knew the long-term side effects. Like I wish that they actually knew what it does to the brain and to the body. Truthfully, like the level of informed consent that comes with, once you start this is the trajectory of what's going to happen to people.
I wish they actually knew their patient's origination story and paid attention to it, because it usually doesn't make any sense for today. And I wish they knew the harm that can be created from taking these medications.
What do you think someone listening right now should do or know before ever accepting a prescription for anxiety or depression?
Try everything else.
I knew you were going to say that. She just did a post on this. It was great. It was try everything else.
Try everything else.
I'm going to add
part of risk benefit alternative. Try all the alternatives.
But here, because people will say, I have tried everything else. So I'm going to add one word in there. Try everything else consistently.
Yeah.
For a long enough period, right?
Correct.
Right. Yes. Yeah. Don't come to me and tell me you changed how you eat for 2 weeks and you did the Mediterranean diet for 2 weeks and nothing changed for you. Yeah. That's not what it's about. Nope. Keep trying.
I feel like someone going on an SSRI in your guys' world is like someone in my world getting surgery.
Yes.
Not perfect equivalence, right? Because some people it's like,
but
or TMS
when you were on our show,
like
it's
the same
very
thing.
similar.
Yep.
Yes.
It's like,
stop the quick fix, because guess what? That surgery you just had, you're going to need it again in the next 3 to 5 years.
And guess what? You're going to need me more now. Like
right.
Much more. And now we don't have to fix your quad weakness. Your quad won't even turn on now,
right?
Because you had your knee cut open. So
that's the equivalent, Clayton.
We went back 5 steps. Yeah.
Yep.
I'm curious on this one in particular. If someone says, I need my meds to function, but I need them, like, this is how I function. I know we in pretty detail covered that, but like, what would like be your first statement? Let's say you're at
you're
party.
dependent. You're dependent.
Okay.
You're addicted. I hate to tell you, but
does that just feel like
your
you slapped
brain
him in
is
the
addicted.
face?
Oh yeah. Like, yeah. But I mean, obviously rapport matters, right? So
for sure.
Yeah. So, but I mean, it depends upon who I'm talking to really, but what you see is what you get. Like, this is the type of therapist that I usually am too. I'm going to say it like it is. Well, that is a measure of dependence.
This is why ChatGPT is so much better, because it's eloquent and we're just like,
we're
nope,
not.
spade's a spade, people. Like,
you guys are gonna love this story. I have a patient who had to use ChatGPT to write us a Google review. This gentleman had been to like 2 or 3 different PTs. He had previously been addicted to, I know, marijuana. He had alcoholism in his past, and I feel like there was one. And then he was also smoking cigarettes, and he has now come off a lot of those. He's had pain just inside of his shoulder blade on his back for like a year or two, and like keeps not getting answers. Went to a PT clinic here in Wichita, which is known as like the Walmart of PT clinics. And I think he saw 5 therapists in 7 sessions. He just like kept getting a new person. And he left his review and he's like, I never got passed around like a doorknob or something like that. I was like, this is a really odd review. And so I talked to him. I was like, hey, thank you for leaving this review. It makes a huge impact. Plus, it makes me, happy to read them. He's like, well, I was going to say passed around like a whore, but I figured that probably wasn't good on Google reviews. So I had to go to ChatGPT, type in my thoughts and say, make this more acceptable.
Just so much more eloquent, right?
Yes.
But that you're right. Like but Terry's not wrong. Like the idea of like with that question you asked her, what do we say? Like, yeah, it's not like day one where I'm like, listen, you're addicted, but it's actually pretty damn close within the conversation I have with people about what synthetic addiction is, right? Like what this comes from, the areas of the brain, and you give them a little bit of a snippet on it, right? Because there's so much stigma around addiction, right? So that's why people can't seem to handle this word. But when we look at how dependent, if you want to wordsmith this, fine, dependency, like it's kind of such an argument online about this. It's so dumb. But yes, you are dependent on this drug.
Your body won't function.
This is why you feel you need it.
That's
and then we talk about like, right. And then we talk, what I was saying earlier, Clayton, I talk with people about like how it impacts your higher order thinking, which is why you're sitting here saying to me, I need this, I need this, I need this. Yeah. Okay. Well, let me tell you what that drug has done to your ability to think critically. Yeah. So then when we start to bring that conversation in, then it becomes a little bit different of a story for people.
I think the hard part is because they've been told that these drugs don't create dependence. Okay. You'll hear that in a doctor's office. This doesn't create dependence. And it absolutely freaking does. 100% it does. Or they say you can't get addicted to this. Okay, but you can become dependent on this, right? Which is evidenced by if you miss it for a day or you don't take it with you on vacation, that you are a hot mess express right now, right? That's dependence. That's not an indication that you need it in the way that you think for your mental health. It's you need it in a way so that you can stop the withdrawal. That's what that is. Yeah.
Agreed. Well, thank you both for coming on. I really appreciate your time, and I would like to do this again at some point in time because clearly this was not even close to enough time, and there's a couple topics we can go deeper on.
That's because we're
with today. Oh, for sure. But I think it also comes from when you've seen this, if you've seen the amount of harm and or bad that's been done, and you hear how many people are suffering from it, and they want answers. It's hard not to be ready to run through a brick wall while also like crying from all like the pain that you witness. And so, from here, if someone is listening and they want to know more, what is your podcast again and how can they find it?
Yeah, we are the Gaslit Truth podcast. And you can find us anywhere that you listen to podcasts. We are also on several socials. We've got a YouTube page, a Facebook page, an Instagram page, and that's all at the Gaslit Truth podcast. So if you just type that in anywhere, you're going to find us anywhere that you listen to your podcasts. You're going to be able to find us as well.
Yeah. Perfect. Same thing with us individually, Dr. Teralyn and Therapist Jenn. Those are our handles for pretty much everything. TikTok.
Perfect. That's what I was going to get to because Dr. Teralyn, that's exactly how I found you, is based on your individual one in particular. And then you also have written a book. Is that correct?
I have, yes. I wrote a book. It's called, I don't have it next to me.
Best Brain.
Gosh. Oh my gosh. It's called,
no.
Here it is. Here it is. It's early.
Okay. All right, I can grab mine.
Your Best Brain.
There it is.
Yes, I did. And Your Best Brain is basically how to get your brain back. How to make your brain the healthiest brain that you've ever had. And also I call it the 3-month warm up to your deprescribing journey.
If I'm not on any psychiatric meds and never have been and don't have that type of challenge in my life right now, could I still benefit from reading that book?
100.
Oh yeah.
And give it as gifts to all of your friends and family because they're probably
Deal.
struggling.
Actually, we have 2 or 3 books in our clinic. Most of it's around menopause, strength training, and then like mobility and stuff. But I'll talk to my owner and see if we can grab some from you and put them in the clinic.
That
I
on
think
the shelf.
Yeah, that would start some good conversations. Plus, your cover is really cool.
Thanks. I did that myself.
I love it.
Oh, what do you know? It matches your colors of your little sign behind you there, Clayton.
Oh yes,
yeah, it
look
does.
at that. That's
Come on, you guys, let's go. We're
think-
gonna
I
HGTV
think
the
that
shit out of
means
this
it's
right
meant to
now. Come on, it's perfect on the shelf. It matches. All right,
I love it. I love it. Okay, well, cool. If you're someone listening right now and you are having these challenges that we talked about, or you know someone in your life, which honestly, based on the numbers, I guarantee you probably know 3 to 5 people in your life on some sort of psychiatric medication, and you really care about their health and you want them to come off of it, please share this episode to them and just be like, hey, I heard this. I thought of you. I really want you to live a long time. I want you to stay healthy. And it sounds like you may be on a path to not being healthy if you're continue on this. So I would like you to listen to this podcast and just tell me what you think. And if you want to go to the Gaslit Truth podcast, go check that one out. My favorite episode was the one with the gentleman who did Mad in America. I was happily angry.
Right?
Yeah. I was like, oh man, he's saying everything I'm thinking. That's cool. But man, F these people.
Yeah,
I'm so frustrated.
I know.
So I get it there, but all the links will be in the thing below. We will have these 2 lovely gals on in the future again. And hopefully you learned a little bit more how to heal without harm, and hopefully you start asking a little bit better questions moving forward. So thank you, ladies, very much.
Thank you.